and welcome to another emergency questions and answered live for families in intensive care and intensive care at home. My name is Patrick Hutzel, founder of intensivecarehotline.com and intensivecareathome.com, and I will be your host for today. You can answer your questions that you have if you have a loved one critically ill in intensive care, or if you have any questions for intensive care at home. You can answer all those, you get all your questions answered here today. I also want to welcome our viewers on replay, because there's always quite a few viewers that watch this on replay. Now, what makes me qualified to answer questions for families in intensive care? My name again is Patrick Hutzel. I am a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse unit manager in intensive care for over 5 years, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending our intensive care nurses and critical care nurses into the home 24 hours a day to replicate an ICU bed, an intensive care bed in the community for predominantly long-term ventilated adults and children with tracheostomies, but also for adults and children on home BiPAP, home CPAP, seizure management, for clients that have a tracheostomy without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, and also for ventilation weaning, nasogastric tube management, PEG tube management, and also for palliative care. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas where NDI is approved, TIC and WorkSafe approved in Victoria. NDIS is obviously all around the country. ICARE in New South Wales, NIISQ in Queensland, as well as DVA all around the country. We as a provider and our clients have received funding through public hospitals, private health funds, as well as departments of health. Now, without further ado, let's go into today's questions. I also want to send you the link here. If you want to talk to me directly, please use the StreamYard link here. Please use the StreamYard link here if you want to talk to me directly. Alternatively, just type your questions into the chat pad and I will answer them here in this video. Now, I want to start actually with a comment that I had from a client this week that we've been working with for quite a few months. And to set the scene, her sister was in intensive care for about 2 months, and she went in there initially with a cardiac arrest and query hypoxic brain injury, and the ICU team was adamant right from the start that this lady, who was in her 60s by the way, should just have life support removed and let her die, because according to the intensive care team, they said that she won't survive. That's number one. So it's in her best interest, in her quote unquote best interest, to have life support withdrawn. And number two, they said if she was to survive, she wouldn't have any quote unquote quality of life, right? And therefore, once again, it's in her quote unquote best interest to have life support removed. Now, as the days were going by, as this lady was in ICU, and this is something we say to our clients all the time, well, every day your loved one survives. You have to question the clinical judgment of intensive care teams, especially when they're saying this patient won't survive, right? You have to question the clinical judgment if that's what they're saying. So, to cut a long story short, they were pushing for a tracheostomy and eventually were pushing for a PEG tube to send her to LTAC. This is obviously a client that is US based. And we strongly recommended to the client not to give consent to a PEG tube, right? Because once a patient has a PEG tube and a tracheostomy in the US in particular, it opens the doorway for hospitals to send, or intensive care units in particular, to send patients to an LTAC facility. LTAC stands for long-term acute care hospitals. And we, once again, strongly advise families to let their loved ones go to an LTAC. It's disaster waiting to happen. So, lo and behold, as time was progressing, the lady was waking up. She was responding to family. She was responding to physical therapy. She was responding to getting mobilized. And eventually, she was getting more and more awake, which is something the intensive care team said she would never wake up because she's got this hypoxic brain injury. Well, it turns out the patient is now on their way to recovery. And I'll read out the message from the client in a minute. But I'm just trying to set the scene that, if you believe the doom and gloom and you don't try at least, right? If you believe the doom and gloom and you let intensive care teams decide for you to stop life support and let your loved one die, well, first of all, you let them walk all over you. And secondly, you never know the outcome besides your loved one dying, right? And one thing that I always say is there's plenty of time to talk about end of life in intensive care, plenty of time. So what's the rush to keep pushing the agenda of end of life? What's the hurry to kill someone? Please explain that to me. So let's read out the email that I had from the client. So, now that I've explained how we ended up here. So here's what the client says. Thank you, Patrick, for your inquiry about my sister. She continues to progress. She skipped rehab and is going on an outpatient basis. She has some neuropathy in her right leg, which is painful and it collapses occasionally. She's able to walk well enough now to do a little grocery shopping. Let me repeat that. She's able to walk well enough now to do a little grocery shopping. Now, this is someone that the intensive care team said she won't survive. And if she will survive, she won't have any quote unquote quality of life. She's going grocery shopping, right? Let that sink in. You have to question the judgment and also the narratives of intensive care teams. Are they getting incentivized nowadays to let people die? I don't know. This is obviously in the US. I don't know. But the question has to be asked. So let's continue in our client's email. So she's able to walk well enough now to do a little grocery shopping. She's able to converse well. Her memory is slowly coming back. She had a memory deficit of many years. Her new neurologist doesn't think she had encephalitis. She thinks it was PRES. Lulu had PRES about 15 years ago with a severe stroke. I understand it's rare to have it more than once. Then it's difficult for me to hear about after she has been through so much. I will be forever grateful to you and your team, for without you, my sister would not be here with me now. You are the only consulting service I know of like this. I have been letting people know about you. I would like to write a book on this experience so that others can learn from it. Would you like to collaborate? I think more people should know what you have to offer. I would like for people to become more aware of these terrible ventilation facilities and the problems with PEG tubes. I have a good friend who worked at the ventilator facility as an RN where they wanted to send my sister. She said she has no doubt that my sister would have been stuck on a ventilator with a PEG tube in there for a very long time. She said refusing the PEG tube and keeping her out of there was the best thing we could have done, from Cassandra. Right? So, if you're watching this and you have your loved one in intensive care and the intensive care team is pushing you to do a trach, to give consent to a PEG, right? The first thing that you need to do is question everything, right? One of my mentors told me, question everything. And I think that's a good, generally speaking, good advice in life. Doesn't matter whether, it's professional or personal. Question everything, right? It's you have to question everything, especially when it comes to life or death. Like, you are watching this, whoever's watching this, you most likely have a family member in intensive care. This is life or death, most likely. You have to question everything, right? How can you not question everything? Many families in intensive care come to us and they say, oh, they come to us after a year, 2 years after they had loved ones in intensive care dying. And they come to us and they say, hey, I've just saw your website. I'm just finding out now that help would have been available. Just finding out now, having second thoughts. Just finding out now that, potentially you could have saved my loved one's life. And can you do a medical record review? Well, we can, but, yes, we can give you closure. We can give you peace of mind. But by then it's too late, right? You have to ask the questions in real time. You have us to look at medical records in real time, not when it's too late, right? And these are some of the biggest mistakes you can make in life. They are life or death mistakes, right? You need to make decisions today that you don't regret in 12 months' time. Let me repeat that. You need to make decisions today that you don't regret in 12 months' time. Because if you make a decision today to have life support removed for your family member, well, guess what happens? Your loved one is going to die, right? They might die without you even knowing that their lives could have been saved, right? And then it's simply too late. And then it's simply too late. So this client obviously has done all the right things, could see the writing on the wall, right? And was reaching out, and with our help, we were able to turn it all around, right? Removing life support in intensive care without patient or family consent, in my mind, could be perceived as murder, right? So what makes you think that a team of random doctors and nurses, yes, they are doctors and nurses for sure, can make life or death decisions without your consent? What makes you think that? Oh, we think it's in your loved one's best interest. Well, do they know your loved one? Do they know them personally? Right? You are the ones knowing them. You know if they're a fighter. You know if they want to live. You know what their plans are. It's only you that knows that, not intensive care teams. So let's move on to, another situation or another client. And if you have any questions in the meantime, please type them into the chat pad, or simply join me on the StreamYard link here. Join me live here on the call, so you can answer, just so you can get your questions answered live on the call here. Now, I want to give another case study today, more or less. So, talking to a client this week, and sorry, I just got to switch my camera for 1 minute, but I will keep talking. Talking to a client this week who has their 86-year-old mother in intensive care. And the intensive care team was actually trying to pressure the family to give consent to a tracheostomy after day 25 or 26 in intensive care, right? So there's a number of issues in regards to that. A tracheostomy, generally speaking, should be done around day 10 to 14 of a patient being ventilated in ICU, right? And the ICU team only came to them at around day 25 or 26. There's a few issues with that. And one of the main issues with that is simply that the first question that you need to ask is, why are they offering a tracheostomy only? Why can't they remove your loved one off the ventilator in that sort of 10 to 14 day time window, right? That should always be the goal, and don't let anybody else persuade you that that shouldn't be the goal. Now, don't get me wrong, a tracheostomy has its time and its place, right? There are times and situations where a tracheostomy has its time and its place. Nothing wrong with a tracheostomy if someone can't be weaned off the ventilator beyond the shadow of a doubt. But if all efforts have not been made to wean someone off a ventilator and the breathing tube in the first place, then that's obviously a big concern, right? That's a big concern. And why has the intensive care team not moved heaven and earth to avoid the tracheostomy? Has your loved one been sedated for too long, right? Have they been on too many opiates, which are painkillers, for too long, right? So unless you know the moving pieces leading up to this, you might have been misled, you might have been misled, or you might be misled as we speak, right? If you don't know what questions to ask, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. I bet any of you watching this would be in that very situation where you don't know what you don't know. Okay, so to come back to our client who, the ICU team was putting pressure on them, saying, look, you need to make a decision to do a tracheostomy. And I would say that after day 25 or 26 of the inability of weaning off the ventilator, a tracheostomy should be done, right? But then it turns out that, once the client gave us access to the medical records, a tracheostomy can't be done at the moment. And here is why. I just read out the patient's sort of medical history so that you can understand why a tracheostomy at this particular point in time is not an option. So patient is an 86-year-old female with significant medical history for hypertension and rectal cancer with radiation therapy, who got admitted on the 29th of November for acute hypoxic respiratory failure, sepsis due to COVID-19. The hospital course was complicated by worsening respiratory status and increasing oxygen requirements. Admitted to ICU on the 1st of December. Patient was eventually intubated, and after DNI reversal. So what does DNI mean? DNI means do not intubate. But obviously they reversed that, the family reversed that, and treated with evidence-directed treatments for COVID-19 and ARDS with dexamethasone. ARDS stands for acute respiratory distress syndrome. It's also known as lung failure. Tocilizumab and episodes of proning. Proning means you're turning a patient onto their tummy for periods of time to drain fluids off the lungs, which has shown to be effective for ARDS in particular. Right? She was also treated with heparin and transitioned to Levodox therapeutic dosing for presumed acute pulmonary embolism and treated for superimposed bacterial pneumonia. Patient has persistent shock state with high oxygen requirements with unrevealing workup to date. Septic workup, including fungal workup and ultrasound, were unremarkable. On the 22nd of December, patient was started on high-dose methylprednisolone for possible organizing pneumonia and transitioned to prednisolone 60 milligram per kilo with slow taper. So methylprednisolone and prednisolone are both steroids. On the 25th of December, patient noted to have abnormal CT chest imaging with pneumomediastinum. CT surgery was consulted. CT esophagram to evaluate for esophageal perforation did not show any evidence of extravasation of oral contrast from the stomach or proximal small bowel, but did show interval increase in pneumomediastinum. Additionally, Her RUE has become more tense with weeping, fluids with CT demonstrating hemorrhage. Orthopedic hand and vascular surgery were consulted and recommended non-operative conservative management. Past 24-hour events, remains on ventilator, PEEP of 6, increased multiple times to 100% for asynchrony-related desaturations, settled at 60% FiO2, fractional inspired oxygen. Remains intermittently agitated. Now, let me stop there. Because this is where really the rubber hits the road. So, past 24-hour events. Remains on ventilator, PEEP of 6, increased multiple times to 100% of FiO2 for asynchrony-related desaturation, settled at 60% FiO2. So, again, this is where families in intensive care don't know what they don't know. For someone with oxygen requirements between 60 to 100%, it is not possible to do a tracheostomy, right? So I'm questioning the narrative here of the intensive care team, why they even bother to ask for a tracheostomy if it is not safe to do so. No surgeon will touch this patient with being on 60 to 100% of FiO2. No anesthetist will anesthetize this patient for a tracheostomy with 60% to 100% of FiO2. Now, keep in mind, room air, the air that you and I are breathing, is 21%. So, if a patient is on 60% of oxygen minimum, that's 3 times the amount, roughly, of the oxygen that we breathe in room air. Once again, room air consists of 21% oxygen. Okay? So, and this is again the biggest challenge for families in intensive care, simply that they don't know what they don't know. So, and I don't know at this particular point in time what the agenda is of the intensive care team. No one can touch this patient. But here is what happened. They really dropped the ball early on to do a tracheostomy when it was time to do so. Now, with ARDS, right, and COVID pneumonia, it is likely that this patient has struggled from day one to come off the ventilator, right? There's no question about that. The question is that, sort of day 10 to day 14, right? Was she ready to have a tracheostomy? Was she stable enough to have a tracheostomy? Here's the issue with a situation like that. One of the main goals of a tracheostomy is simply to reduce sedation and opiates, to basically get patients out of an induced coma. That is the goal of a tracheostomy, or is one of the goals of a tracheostomy. It's not the only goal, but it is one of the goals of a tracheostomy. So, the minute you can, you do a tracheostomy and you can stop opiates and sedation, right? It's then easier to wake up a patient, right? So let's take this patient, 25 days of intubation with a breathing tube. Now, a breathing tube is extremely uncomfortable, right? And often requires an induced coma, right? For the patient to tolerate the breathing tube and the mechanical ventilation. So imagine someone's shoving a tube in your throat halfway into the lungs or a few centimeters into the lungs and then is ventilating. That would be extremely uncomfortable, would be extremely painful. And that's why current practice, in most ICUs is sedation and opiates. So every day, someone is in an induced coma, right? It's not moving or can only be moved by nurses, by physical therapists, by physiotherapists and so forth. Muscles are deconditioning. That is real, right? Therefore, the longer someone stays in an induced coma and is being mechanically ventilated, right, the longer it usually takes to get them off the ventilator because patients are simply deconditioned, right? The breathing muscles are not being used when someone is in an induced coma and on a ventilator, right? So the breathing muscles decondition, creating almost a vicious cycle of patients needing more time to wean off the ventilator and the breathing tube, right? So, and now this lady is still ventilated and she's still in an induced coma, right? So every day she stays in an induced coma, it's less likely she can be weaned off the ventilator, right? So let's continue in the assessment here of the patient. Patient remains intermittently agitated. Levofed is off. Levofed is inotrope or vasopressor for hemodynamic instability to maintain a blood pressure that is actually compatible with life and with organ perfusion, right? So that's quite a common drug being used in ICU. Stable on vasopressin. Vasopressin is another vasopressor or inotrope which is being used when patients have a low blood pressure, and the blood pressure could be as low as that it's not compatible with life, or it could not be compatible with organ perfusion. And if the organs are not perfused, then eventually a patient could deteriorate and die. Midodrine was started. Midodrine is another vasopressor or inotrope being used for low blood pressure or for blood pressure that's not compatible with life. Persistent low-grade fevers on high-dose prednisolone and broad coverage with recent posaconazole added. AM chest X-ray per radiology with right 4 mm apical pneumothorax and worsening subcutaneous emphysema. Well, here is another indicator that tracheostomy is out of the equation at the moment, right? A pneumothorax can be a contraindication to a tracheostomy. It depends on the size, right? Some pneumothoraxes have to be treated with a chest drain, right, so that the air can be sucked out of the lungs, right, and close the hole. And some pneumothoraxes can just need to be treated conservatively as the hole closes eventually if the hole is small. Okay, and also it's a subcutaneous emphysema. What that means is a subcutaneous emphysema is that there's air in the tissues of the skin and it really blows up the skin. That can be as bad as that the face is swollen, right? And those are all contraindications for a tracheostomy. So why would the intensive care team even ask for a tracheostomy in a situation like that? Well, I argue they've asked for a tracheostomy to do a tracheostomy in the PEC as quickly as possible, and then do a PEC tube as well, and then send this lady out to an LTAC facility as quickly as possible. The problem here is that the system in the US in particular is not designed to let people wean off the ventilator as quickly as possible. The system is almost designed to let people stay on ventilators. If they can't come off the ventilator, let's do a tracheostomy and a PEC tube and then ship them off to an LTAC facility. And that is really, really bad, right? That is really, really bad. Because LTAC facilities are simply not set up to have long-term ventilated adults and children be looked after in there. They're not set up for it. No matter what you want to tell me here, they're not set up for it. Now, so let's carry on with the history of this particular patient. So medications she's on ascorbic acid, she's on aspirin, she is on enoxaparin, which is Levinox, which is a blood thinner, twice a day on 80 milligrams. Bear in mind she's got a history of a PE, which is a pulmonary embolism, which is why she's on such high doses of the Levinox, because 80 milligrams twice a day is quite a high dose. She's also on furosemide, which is Lasix, twice a day, 60 milligrams. That is to drain the fluids. She's very edematous. That means she has lots of fluids in her legs, in her arms, which is a combination of two things. It's a combination of being immobile, right? It can be a combination of being immobile, a positive fluid balance, meaning going more in than out, and then it's often a result of a weak heart, which this lady happens to have as well. She's on insulin, she's on atrovent nebulizers, she's on ivermectin, she is on metolazone, she's on midodrine, which again is the vasopressor, she's on pantoprazole, she's on tazocine, antibiotics, She's on posaconazole, which is an antifungal medication, prednisolone, which is steroids, spironolactone, which is a potassium-saving diuretic. She's on Bactrim antibiotics. She's on thiamine, vancomycin, and she's on vitamin D. She's also on dexmedetomidine, also known as Precedex, which is a sedative and pain medication to keep people in an induced coma. She's on hydromorph, which is hydromorphine. She's on norepinephrine / levofed. She's on vasopressin. Both norepinephrine, levofed, and vasopressin are vasopressors, once again, that are exclusively being used in ICU when blood pressures drop to the level where it's incompatible with life or incompatible with organ perfusion, where the blood pressure is so low. Now, she's also on intermittent magnesium infusions, midazolam infusions, but also oxycodone, PRN as needed. So, the vital signs are, blood pressure is 100/45, sometimes it's as low as 90/50, 113/62, which is, once again, why she needs the vasopressors and inotropes. From a ventilation point of view, she's in a pressure-controlled ventilation mode. Why is she in a pressure-controlled ventilation mode? Well, I can tell you straight away that with ARDS and COVID pneumonia, the lungs would be so stiff that if you use a volume-controlled ventilation mode, the chances of a pneumothorax are even higher. She already had a pneumothorax, so I don't know whether they changed the ventilation mode as part of her having sustained a pneumothorax, and whether she was potentially in a volume control mode before. And here's the reason why it's more likely for volume control to cause a pneumothorax then, as opposed to pressure control. With pressure control, you control the pressure, which means you can say, I only want 20 centimeter of water in the lungs maximum. And if you limit the pressure, you limit the risk of a pneumothorax. If you use volume control, you're controlling the volume, but you're not controlling the pressure, which means, if your volume is 300, but there's resistance in the lungs, there's sputum, then you could create so much pressure that the lungs literally pop and you have a hole in the lung, and then you have a pneumothorax. Now, that's overly simplistic explained, but I hope you get the gist. So having this lady in a pressure controlled ventilation mode makes sense, given that she's already sustained a couple of pneumothoraxes. She's got a respiratory rate of 24 breaths per minute, which means, she's getting guaranteed 24 breaths per minute from the machine. She's on FiO2, like I mentioned earlier, 60% in this particular snapshot, but it has gone up as high as 100%. Just to recap, room air, the air that you and I are breathing, is 21%. So she's on needing 3 times the amount of oxygen than the air that you and I are breathing in. PP6, the actual respiratory rate is 33, which means she's breathing on top of the ventilator. Spontaneous volume is around 470 mils. That's okay. Minute volume is 11.1. And the pressure is set at 28. Now, the RASS is -1 to +2. RASS score is a sedation score, and you can actually, you should actually sedate a patient according to the RASS score, and always with the goal of letting them wake up, right? If she's a RASS of -1 to +2, that means she is still heavily sedated. That means she's only lightly waking up, right? That is what is needed for now, according to the intensive care team, because if she was waking up, she would be breathing against the ventilator. That was part of the report earlier. If she is breathing against the ventilator, one of the issues there is that with such high oxygen requirements, she would not be adequately ventilated, right? So what that means is, if the ventilator can't ventilate it because she's fighting against it, there's a risk of other complications such as, respiratory arrest, hypoxia that could lead to all other complications such as no organ perfusion, cardiac arrest, and so forth. So, what else? She's got a Foley catheter because she's unable to void, to pass urine. Then pulses are present and symmetric in both upper and lower extremities, so that's a good sign. She has warm arms, but she has cool to cold distal feet, right worse than left. Now, why is that? I can tell you why that is. When someone is on vasopressor, such this lady, such as she's on Levophed and vasopressin, and now she's on midodrine. So what do these medications do? These medications squeeze the arteries and the veins, and therefore the blood is being concentrated towards the heart, so it can increase blood pressure, right? And that's why patients often end up with cold feet or cold hands while they're on vasopressors, right? Because their blood vessels are being squeezed, right? So then the neurology assessment says agitated delirium, moves all to noxious stimuli and at times to command. Attempts to communicate verbally, nods, yes or no. Skin bleeding, dressed with diffuse edema, sensation intact per patient, moves fingers to command. Okay, so, but the question still remains, why are they pushing for a tracheostomy even though it wouldn't be safe to do a tracheostomy, right? Like I said, it's all about this narrative, get consent from a patient that as soon as the patient is stable enough to do a tracheostomy. Now, in this situation, it looks to me like a tracheostomy is the right next step, simply because she's been in ICU for too long and she's been ventilated for too long, and they need to eliminate the Precedex, right? Also, she is on such high ventilation support and on such high other life support mechanisms such as the vasopressor support, right, that she won't be a quick wean by the looks of things. And if someone is a slow respiratory wean, that's a technical term for, someone is ventilator dependent and needs to be weaned off the ventilator over time, right? That is when a tracheostomy has its time and its place, right? Now, whether they've potentially dropped the ball earlier in the course of this ICU treatment, I don't know. I'm just looking at, sort of the current snapshot. But for someone with ARDS, it is very unlikely that someone can be extubated with ARDS as long as the ARDS is present. Once again, ARDS means acute respiratory distress syndrome, and it means lung failure, right? So, and also while I'm going through this, if you have any questions, type them into the chat pad. Or if you don't understand anything that I'm explaining, please ask questions here, or join me live on the StreamYard link here. Talk to me if you want your questions answered. I can see there's quite a few people here. And talk to me. In the meantime, I'll just keep plodding along. But if you have a question, now is your opportunity to get it answered live on this show. We usually go for up to an hour, so I've got about 20 minutes left. If you want to talk to me now is your chance. But one of the problems is here in this particular situation. This lady is still on Precedex, which is a sedative, and she's also on hydromorph. Hydromorph is like a morphine-based medication. Now, the hydromorph in particular is addictive in nature, right? Again, what are the side effects of these drugs? Side effects of hydromorph, for example, is respiratory depression. So what that means is it counteracts the actual goal to wean someone off a ventilator. Opiates such as morphine, fentanyl, hydromorph, oxycodone, you name them. One of their main side effects is respiratory depression. What that means is it stops patients from breathing, right? And if someone is on a ventilator, you need to stop the opiates as quickly as possible, but you also need to stop the sedatives as quickly as possible, right? Peter, nice to see you again. You're asking what concerns would you have before attempting to remove the ventilation? Plus, happy 2025. Yeah, happy New Year to you too, Peter. Would you have before attempting to remove the ventilation? In this particular situation, she can't come off the ventilator, and I'll tell you why. She's on 60% of FiO2, right? Once again, and it's going up to as far as 100%. This patient wouldn't survive off the ventilator. That would be my biggest concern here, right? And also, she's on a breathing rate of 24. That's guaranteed by the ventilator, right? While she's on sedatives and opiates. So, what needs to happen in a situation like that? First of all, she needs to be weaned off sedation and opiates. That's the first thing that needs to happen. And as you wean someone off sedation and opiates, you need to reduce the ventilation support, which means in this situation, she needs to go from a rate of 24 breaths per minute guaranteed by the machine. First of all, you would need to go down to 20, then you would need to go down to 15, maybe then down to 10. But all the while, you also need to make sure that the patient is adequately ventilated, right? And you can assess that by looking at the oxygen sats, but you also need to assess it by looking at the patient to see whether they've got a good skin color. Is their skin color potentially gray or blue? That would indicate they're not ventilated well enough, right? Then what also concerns me here, her pressures on pressure controlled ventilation are very high. They're sitting at 28. It's too high. If you remove the ventilator here, the patient will die. But she's also on 60% of oxygen, right? Once again, room air, the air that you and I are breathing, is 21%, right? So, even if you extubate someone onto BiPAP, you wouldn't be able to maintain the pressures. So Peter, you're asking, how do you find those records of breaths per minute whilst on the respiration rate? Yeah, so it's a good question. When we look at medical records, Peter, we obviously know what we're looking for. When I look at documents, doctors, nurses, what they're documenting, I know what I'm looking for, So I can see when someone is in a pressure controlled ventilation mode, I already know that they would have a set rate. I already know that because that is part and parcel of the pressure controlled ventilation mode. I guess that's obviously where my specialized knowledge is coming in as a critical care nurse. When I look at the reports, I just go like, oh yeah, sure, she's on pressure controlled ventilation. What's the rate? What's the pressure control set at? I automatically look at that because, it's just part of the skill that you have as a critical care nurse, if that makes sense. So sometimes you might look at a respiration rate and you might see it's 22, but then the next question is, what are the ventilator settings, right? So there's a difference if someone is has a breathing rate of 22 breaths per minute and is in a pressure support ventilation mode, right, as opposed to a pressure controlled ventilation mode, right? So there's a difference there. And again, this is where our skill as critical care nurses or doctors is coming in, where you know straight away the difference. It's not one size fits all. Just because someone has a breathing rate of 22, does that mean they're breathing spontaneously? Or does that mean the ventilator is doing the breathing for them? Does that make sense, Peter? Or is that too sort of, am I talking too medically here? Okay. Then let's look at what other things are happening with this particular patient. Okay, with the hypoxia under ventilation, when are you concerned in the drop in oxygen rate whilst on ventilation? Yeah, that's a good question. With the hypoxia under ventilation, when are you concerned in the drop in oxygen rate whilst on ventilation? Yeah, great question. So I would be concerned if oxygen sats would drop below 94 to 92. That's when I would be concerned. assuming there's no underlying respiratory condition. Let's just say for someone with COPD or asthma, I might be happy with a SATs of 92, but for someone that generally speaking has healthy lungs, I would be concerned if it drops below 94 or 92%. But if I see that, right, the next step would be, especially in a hospital environment, would be to do an arterial blood gas to confirm that those numbers are accurate. Sometimes you might get a SATs of 92 on someone's finger, but they have really cold fingers, and therefore it might not be accurate. So to check the accuracies, you actually need to do an arterial blood gas ideally, and that's where you can see, oh, we've got a SATs of 92. Yep, that's confirmed in the arterial blood gas. Now we've got a PO2, which is the oxygen gradient in the arteries. PO2 is 55, and then you can probably say, oh yeah, this is actually no longer adequate, and hypoxia is most likely the case here. Under 97% percentage? No, not really. 95 to 97, not really. Yes, it would be low in the blood gases also, very much so. Because otherwise it wouldn't correlate really. It could just simply be it's not picking up properly. Like I said, someone might have really cold fingers. That could be one of the reasons, and their actual oxygen sats is 100%, right? Or also sometimes, especially with female patients, they might have painted fingernails, and then it also doesn't pick up properly. So if it's low in the blood gases, also on multiple occasions, under 66% percentage, that's a medical emergency. Assuming it's accurate, it's a medical emergency. And you would also pick up on the skin color would change. If you have a patient with 66% oxygen saturation, they would be getting blue slowly, but very surely, and then also very quickly. To as low as 35% for an extended time? No. I argue 35% of oxygen saturation will lead to inevitable death within minutes. Are you suggesting that someone had unconscious in convulsions? Yeah, in convulsions. It probably depends, Peter. Probably depends, Peter, whether someone is ventilated during that period or not, right? So if someone is ventilated during that period where they have convulsions, at least there's something going in, right? And if someone is having convulsions and someone is having intravenous access, they can probably break those convulsions by giving midazolam or diazepam, right? And then once they break those convulsions and someone is ventilated and the ventilator kicks in again, and you can adequately ventilate a patient, then the oxygen sats usually comes back, assuming there's no mechanical obstruction. No ventilation, a 15-liter rebreather. Still, do they have IV access? If they have IV access and they're in a controlled hospital environment, you could give benzodiazepines such as midazolam, diazepam, and you would break the convulsions, and then hopefully the oxygen is going in. But what certainly could happen during that period, when someone is only having 35% oxygen saturation, what could happen during that period is there could be brain damage. If the oxygen is not perfused with, if the brain is not perfused with enough oxygen for more than 3 minutes, there could be irreversible brain damage. Yes, obtained whilst on the emergency room floor. 15-liter rebreather. Yes, all meds discussed. Yes, obtained whilst on the emergency. Elaborate on what, Peter? Elaborate on what? Can you be more specific? What do you want me to elaborate on? A whole episode on those matters, please. I'm not sure what you exactly mean. So I think I walked through it step by step as you were giving me hints here. Extended hypoxia. Oh, sure. Extended hypoxia. Well, extended hypoxia. So the research is out there that if any organ doesn't have enough oxygen perfusion for more than 3 minutes, there could be irreversible damage to an organ, which includes the brain. So I argue if someone is having a 35% oxygen saturation for more than 3 minutes, I argue there could be irreversible brain damage, right? Because 35% oxygen, that's not enough to perfuse any organ. Now, if it's lasting less than 3 minutes and you can recover back from a 35% oxygen saturation, hopefully no damage has been done. Can I suggest links under Australian standards? Maybe just type into Google, when does brain damage occur without oxygen? Just Google something like that, right? But it's worldwide. You will see that it's worldwide. That the research suggests that for more than 3 minutes without oxygen perfusion to any organ, there is going to be irreversible damage to the organ. So 3:55 to 16 minutes. Yeah, that's a long period of time. But the question is, what did they do? So you're suggesting there has been an oxygen saturation of 35% for 16 minutes. That's a significant period of time. And if there was only a non-rebreather mask and no intubation or no BiPAP, with a 15-liter rebreather, what might the heart rate received in damage? I don't know. The question is afterwards, did they do, was there any sign of cardiac damage, of the heart damage? Was there any sign? The critical record suggests that, okay. Did they, for example, do an angiogram or an angioplasty afterwards? Did they do an ultrasound of the heart? What suggests that there has been any cardiac damage, right? Have they done a troponin check, i.e. troponin check in the bloods is suggesting of a heart attack. So when someone has a heart attack, it shows up in the bloods with a positive troponin test, right? It's a specific marker that indicates a cardiac event, i.e. heart attack, right? But a heart attack also can be confirmed by an angioplasty or an angiogram, and not an angioplasty, by an angiogram, right, in the catheter lab. It can also be verified in an ultrasound, right, in a heart ultrasound, right, and in an ECG, in a cardiac ECG. That's also another sort of piece of evidence in the puzzle to confirm a heart attack. Nil positive event for troponin. Have they checked for it? Have they checked for it in the first place? That's a question here. So, but 35% of oxygen saturation is really, really low. Really, really low. During convulsions, I'll give you this hint. During convulsions, there's a high chance this is accurate, right? There's a high chance this is accurate. However, there's also a chance that, maybe the fingers were cold, right? And because of that, it wasn't picking up properly. And this is where, again, the arterial blood gas would come in, right? But they may not have had the time during such a medical emergency to do an arterial blood gas, unless the patient had an arterial line, right? So it really depends on what is exactly, what was exactly happening, right? So blood gas results, do you have them? for that period? Is it correlating with what the oxygen saturation shows? Is the oxygen saturation in the blood gas also 35% or thereabouts, give and take? Because then your PO2 would be really poor. IDK, blood gas results, nil positive event. To the best of my knowledge, and I'm happy for you to view and confirm. Right. We would need to look at the medical records, Peter, to confirm what it requires more detail. Would also be very interesting to see what medications were given during that event. As all relevant departments agreed with my point of view. Okay. Yeah. So look, I don't know, what else has been happening there. I'm also wondering, Peter, with the non-rebreather, did they potentially take that off, and did someone give oxygen via the mask? Yeah, you're more than welcome to email me. The email, Peter, is support@intensivecarehotline.com. That's again, support@intensivecarehotline.com. And hi, Helene, nice to see you again. Thank you for showing up. Now, I will wrap this up in a minute. If you have any questions, please reach out to us at intensivecarehotline.com for consulting and advocacy for families in intensive care. If you need intensive care at home nursing, go to intensivecareathome.com and reach out there. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related there. Now, also, if you like the video, give it a like, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, comment what you want to see next, what questions and insights you have, and share this video with other friends and families that you have that might need insights for families in intensive care. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. We do review medical records in real time so that you can get a second opinion in real time. And we also review medical records after intensive care if you have any questions, unanswered questions, if you need closure, or if you are suspecting medical negligence. We also do NDIS specialist nursing assessments done by critical care nurses with a legal nurse consulting background. Now, I want to thank you once again for showing up, and I'll see you again next week at the same time, and I will talk to you then, and look out for my quick tip videos during the week. Take care for now and have a wonderful week, and Happy New Year again. Take care.